Where's my, excuse me, let me just put this on.
You may have to adjust that mic a little like that.
All right, let's see.
No, I'm talking.
Oh, okay. Okay. Okay with you? Yep. Great. Can you hear me? Excellent. Well, thank you for inviting me. This is truly a pleasure. It's nice to see so many young people interested in global health as my career is winding up. So it's good to see we have a nice pipeline of people to take over these jobs. As Ruth said, I was the Chief Nursing Officer for the Clinton Foundation for almost 12 years. And I started out in HIV nursing. So I've been a nurse for almost 40 years. I was practicing in Rhode Island, and I was working in a hospital-based HIV clinic for several years. That clinic closed, and then I moved on to doing community-based HIV nursing. And around this time, in about 2000, my youngest child was a junior in high school, and I started to think about what's next for me. And I was thinking, you know, something international. That'd be so exciting, so interesting, something new, just for me. I was obviously a nurse, but also taking care of my children and my home for many years, and this was a time for me to try something different. So I started to look around on the internet, what was out there, and I wasn't ready to quit my job, but I thought, I'll do something, some kind of volunteer thing. And you know, now looking back on that, I realized I went for a week to Honduras. That's, you know, not really an effective thing to do, but I did it to kind of put my toe in the water and to see if it was something that I would like. And you know, I paid my own way. It was very expensive. We went out to some rural place and handed out medicines. It was really, now looking back on it, a little bit embarrassing, but I understand that for me, it was a big leap. And I did it, and I'm not sorry I did it, but I always advise people who are gonna go on like a 1 week, 2 week, 3 week mission trip, that it's really more about you than it is about the people that you're gonna interact with. And so that's okay. That's okay, because you might be figuring out your life plan. So I did that. I came back and I said, oh yeah, I think this is something I would like to do. The next year I went to Belize, and because I had a friend from Belize, and she asked if I would go because they were just starting HIV treatment in Belize. And so I went 3 times that year. And that was the time that people were just starting to talk about treatment outside of the US and Europe. And in Belize, they had gotten the price of antiretrovirals down to $75 a month, and that was unbelievable because it was about $15,000 a year in the United States. So, but it was still too expensive at $75 a month. It was still too expensive for anybody except the most wealthy people to afford antiretroviral therapy. So it was available, but really not accessible to most people. So I started to read up on what was happening in HIV care in other countries. And I came across some articles on the Clinton Foundation and President Clinton and trying to negotiate the prices of antiretrovirals. So I said, oh, this is really interesting, because I saw that they were getting these incredible prices for the antiretrovirals. At the same time, I saw that the CEO of the Clinton Foundation was speaking at Brown University. So I went and I listened, and it was very inspiring and very challenging, and it was exciting. And at the end of his talk, he said, some of my staff is over there in the corner if you want to talk to them. So I went and I talked to them, and I said, I've been doing this work in Belize. Is there any chance that Belize could get access to the prices that the Clinton Foundation is negotiating? And they said, Yes, as a matter of fact, we just talked to somebody from the Ministry of Health last week, and we're setting up a relationship. But they said, but could you help us? Because I had given them my card, and I was an HIV nurse. I was specializing in adherence, which was helping patients to take their medicines and to adhere to their treatment regimen. And I said, sure, I can try. And they said, okay. Suddenly, they start sending me all these documents to review, these national plans. And I said, oh my God, what did I get myself into? I didn't know anything about global health, but I tried my best. So we come to 2004, and I'm trying to help them a little bit, but I'm still doing my job. So this is where we come in. So I wanted to tell you, oh shoot. Let's see if I do that. No? Can you help me with this? It seems to be gone. Oh. They were down here. I'll keep talking because I only have 45 minutes.
There, wait, there, okay, so it should come up. Okay, you know why? Because it's on. Did somebody switch that out? That's why.
Yes, somebody did.
Okay.
Okay, now let's see. There we go. Okay. Okay, great. So I thought I'd tell you a little bit about my personal journey, because I think that probably you all have an interest in global health, but probably not a clear idea of what you could possibly do with it. And I want to tell you that there are fabulous, interesting opportunities for all of you, no matter what your discipline is. So it could be economics, it could be biology, political science, anthropology, engineering, nursing. There is a place for you. And there's really exciting work to be done. So this is how CHI began. So the Clinton Health, we were the HIV/AIDS Initiative at that time, but now we're the Clinton Health Access Initiative. In 1996, it was determined that triple antiretroviral therapy could stop the advancement of HIV disease and provide people with a long and healthy life. I'm sure you know something about HIV. We had HIV in this country from the early 80s. We know now that HIV was present in sub-Saharan Africa, probably back to the 30s. But it was so-called discovered in the United States in the early 80s. And at that time, there was no treatment at all. And virtually everyone died. In the mid-'80s, we started using monotherapy, so one drug at a time to try to treat people. So it was AZT and D4T, and there was some benefit. People might get a year or two more of life, or they might try the AZT for a couple of years, and then when that wasn't working anymore, they'd try something else and try something else. Some people were able to stretch that out until the 90s, till 1996, when triple therapy was available. And so there are people who have been living with HIV for almost 40 years now. So after 1996, it changed the course of the disease completely. In the United States and Canada and Europe, where people could afford this kind of treatment. But in every place else in the low-income countries, any money that was going to HIV was going to so-called prevention activities, which was mostly telling people not to have sex or to use a condom. And maybe some money was going to palliative care, helping people die. But there really was no global push for treatment in these countries. And many people said it's impossible to treat a disease like this in a low-income country. The drugs are too expensive, they don't have the healthcare infrastructure, they're not used to treating a chronic disease. Most treatment in these countries at that time was for acute care, So somebody's got diarrhea or malaria or whatever, and they would come in and they would get treated and they would go home, but they wouldn't be coming back every month or every few months to treat their high blood pressure. So many people said it wasn't possible, but there were a few brave souls who said that can't be right. It can't be right that just because of where you're born, you will never have access to treatment. And there were a couple of groups who tried in the late 90s to set up HIV treatment programs in sub-Saharan Africa. MSF, so Médecins Sans Frontières, Doctors Without Borders, they did a program in South Africa, quite successful. The other thing that people said is, oh, people in Africa, they're not used to taking medications, they won't be able to take the medicines every day, they don't have watches, they won't know what time to take the medicine. A lot of really ridiculous things were said to justify not providing treatment. But it was mostly about the money. Obviously, it's really expensive. But the groups that did try it and paid for it themselves were highly successful. People were more adherent to their medications in sub-Saharan Africa and these low-income countries than the people in the United States were. And they had very, very good results. Even with all the other issues, so not having access to clean water and poor nutrition, even in spite of those things, people did really well on antiretrovirals. So it proved the concept. And then people started to talk about it. How could we fund this? How could this happen? And in 1999, WHO started talking about how we would put together this fund and there would be this major attack on HIV, and talk and meeting and meeting and meeting year after year, and it never happened. But in 2002, the Global Fund was established. Now, the Global Fund is a big organization that collects funds from high-income countries and some private donors, like the Gates Foundation, will give to the Global Fund, and then they distribute it to countries for AIDS, TB, and malaria projects. In 2002, CHI was formed, and in 2003, PEPFAR was announced by President Bush, and also in 2003, the WHO 3x5 initiative was launched. So I want to tell you a little bit about CHI and how it came to be. So after President Clinton left office in 2001, he was looking for what would be his next endeavor, and he wanted to do something around global poverty, but his inclination was it would be something around economic development, so helping to create jobs in low-income countries. But the more he talked to people, the more he was convinced that if something wasn't done about HIV, then the economic development was not going to matter. And it was actually Nelson Mandela who convinced him that the focus of his foundation should be on HIV in low-income countries. And because what was happening at that time, there's several countries in sub-Saharan Africa that had 30% prevalence. 30% of the adult population was infected with HIV. And they had no access to treatment. And who are these people who get infected? They should be your most productive members of society. They're your young adults. They're your teachers and your nurses and the farmers and the shopkeepers and the political leaders and the bankers. They're the people who make a society work, and they make families work. And what was happening? They were dying. And all these children were being left without parents, and all these jobs were being left unfilled because the people were sick and dying. So he decided to focus on HIV, but with that business approach. So what was the main barrier to HIV treatment? It was the cost of the medications. As I said, at that time it was about $15,000 a year in the United States for a first-line regimen, so the most basic 3-drug combination. So triple antiretroviral means 3 different antiretrovirals. And obviously nobody in the world can afford that except us and Europe. So how are we going to get the price down? That's the first barrier. So he and Ira Magaziner, our CEO, went to the US drug companies to say, there is a market out there of 33 million people who are infected with HIV. It's a huge market. What's the best price you can come up with to get access to that market? The US drug companies were not interested in that negotiation, so they went to the Indian drug companies and negotiated with them. And negotiated on every aspect of production of the drug. So from getting the raw materials to transforming the factories into, so maybe you had a factory that was producing 5 different medications, they would just get rid of all those and do one. So one factory is going to do AZT. So really huge amounts of the drug. And we said to them, if we can guarantee you a market of X number of doses, what's the best price? And in 2003, we negotiated the price to $138 per person per year for the first-line regimen of antiretrovirals. That changed everything. So that made it possible for governments, for faith-based organizations, for NGOs to buy the antiretrovirals and provide them to people free or at very low cost. So everybody benefited from that. Everybody benefited from that negotiation. Now, we have continued to do that over the years on different antiretrovirals, on malaria medications, on vaccines, family planning devices. We have a huge team that negotiates and researches products and gets the best price. So now there's a consortium of over 70 countries that access our pricing. So now we've promised the drug company a certain market, but in these countries, nobody's on treatment yet. So it's starting from zero. And if you said, okay, Kenya's gonna say that they'll buy 100,000 doses of AZT next year. Okay, quick, how are we gonna get these people who are gonna use 100,000 doses? And so what we did, this is simultaneously, is send teams into each country to work with the ministries of health. Every country had like a national AIDS control organization. They were called different things in different countries. I think it was NASCOP in Kenya, right? And so they would be coming up with national plans of, okay, what's going to be our strategy? How are we going to get from zero to this? And so they have to come up with plans for how are we going to test people? How are we going to diagnose them? How are we going to get the test kits? Who's going to pay for them? How are we going to train people to use the test kits? How are we going to make sure that these are valid results? Then, once the people are tested, how are we going to find out, do they need treatment? Because at that time, you didn't get treatment until you needed it, until your CD4 count, which is a whole other issue, was at a certain level. So until your immune system was compromised, you didn't get treatment. So there was rules about that because these countries could only afford so much, so they couldn't be treating people that at that time we didn't think needed it. So how are we going to find out how sick they are? Because there was no CD4 machines, so you couldn't have laboratory diagnosis. You had to have diagnosis based on symptoms. So that's training a whole army of doctors, nurses, and other people in the country about a disease that they didn't know much about. So we worked in each country, so we would bring in whoever, doctors, nurses, economists, pharmacists, a retired CEO of a pharmaceutical company, whatever we needed, we would bring in to sit with that Ministry of Health and come up with their national plan. And in that way, we help them to create the market for these drugs that we had negotiated. Now, we have country teams in 33 countries at this point, and we have about 1,500 employees worldwide. When I joined, there was about 10 of us. So it's been very interesting to see the growth. PEPFAR has been amazing. This has been like one of the things Americans should be most proud of is the amount of money that we put into AIDS relief and in a number of countries. The 3x5 initiative was a WHO initiative that finally, after all these meetings from 1999 to 2003, they came up with this initiative that they were going to put the goal was 3 million people on treatment by 2005. That was in a 2-year period. It's from December of 2003 to December of 2005. Very aggressive. It didn't happen. 1.3 million people got put on treatment, but it changed everything. And people thought Jim Kim, who was the chair, what was he called? Chair of the WHO, who's now the president of the World Bank. People thought he was crazy. But he pushed forward with this. And no, it wasn't successful, but it made all the difference because people said, it set a goal that people hadn't had before. Before it was like, no, it can't happen, no, it's too expensive. And he's saying, yes, it can happen, and we're going to do it, and we're going to do it by 2005. Now, today, there's about 18 million people on HIV treatment throughout the world. So it didn't quite get there by 2005, but after that, it really started to ramp up quite rapidly. So I just put this picture up because this was my first trip to India. So I have to tell you then how I got the job. So I was doing HIV nursing. I was doing it in the community, so I was in a patient's home, and I got a phone call, my cell phone, and it was Ira Magaziner, the CEO, and he said, yes, Ira Magaziner, he's a man of few words. Can you travel? And I said, yes. He said, okay, do you want to go to India or South Africa? And I said, oh my God, what is he talking about? What does that mean? And, I had been doing these trips to Belize, and it was costing me a lot of money to go back and forth, and I had 2 kids in college at the time, and I was like, well, can I just ask you, are you going to pay my airfare to get there? And he said, yeah, I'm offering you a job. Tell me what you make now and I'll match it. And I said, yes. And he said, okay, can you go on Thursday? And I said, no, I have to talk to my husband, and I have to talk to my employer, and I have to talk to my patients, because I had a lot of patients, and I had a very close relationship with them, and I could not just leave them high and dry. And he said, okay, tell me when you're ready. So I talked to my husband. He said, hey, sounds great. And my employer, I just told him, hey, I'm leaving. I don't know how long this is going to last. I don't even know what I'm signing up for, to tell you the truth. And then I talked to my patients. That was quite hard. There was a lot more tears than I ever expected. And so then I started, and I told him, okay, I'll go to India. So my first trip was to India. I didn't know what I was doing. And he didn't really tell me anything. So fortunately, somebody met me at the airport with a sign with my name on it. I was like, whew, okay, they take me to a hotel, and the rest is history. But as I was preparing for this, I was looking back at my journal from those days and reading about what I was feeling in the airport in Boston, and what I was feeling when I got to the hotel, and what I was feeling a couple weeks later when I said, what have I done? I gave up a job I loved. I knew I was good at it. People really liked me. And now I don't know what I'm doing. And nobody's telling me what to do. I've made a huge mistake. And this is like this global Clinton Foundation, and I am letting them down, and they're paying me to let them down. Oh my God. I'm reading these pages on the train, and I'm going, oh, I remember how terrible that was. But then you turn the page, and it was like, I had such a great day. I went to the hospital in New Delhi. What I decided to do, and for those of you who are nurses, you will learn this in your careers, like nursing prepares you for almost anything. And I just said, okay, what would I do? what would I do if this were like a nursing problem? Okay, you kind of assess it and you come up with a plan and then you just like go for it. So I just started reaching out to nurses, and I went to the biggest hospital in New Delhi. It was the AIMS something, All Indian Institute of Medical Sciences, I think it was. Huge place. And I went to see the chief nursing officer, and I introduced myself, and nurses are lovely the world over. So welcoming and so helpful. And she was like, oh, thank you for coming. And she took me and she explained. She took me up to meet the infection control nurses. They were lovely. They took me around and showed me the wards. I didn't know what a ward in India looked like. You know, you've got these ideas in your mind about what something looks like, and then you're there and you go, oh. I remember in the hallway there were signs, please don't feed the monkeys. Monkeys can carry rabies. And I thought, and I went, ha ha ha, and there's no, it's serious. And I was like, oh, because the monkeys, when you first see them, they're everywhere, and you're like, oh my God, look, monkeys. But they're like rats. You know, I mean, they're creepy. But, you know, it was such a learning experience. So then, like those nurses introduced me to other nurses, I was able to go to the HIV clinics and sit with them and watch. And I ended up knowing more about HIV care in India than all of my friends with their suits and ties and MBAs did. So they were saying, well, they would say something in a meeting, and I'd say, no, it's not like that at all. There's 200 people in the waiting room, and they're pushing their way in. They've got their chart, and they're pushing it at the doctor, and he's scribbling something, and they move on, and the nurse hands them a bottle of pills. That's it. That's HIV care for those people who are lucky enough to get into that clinic. And they walked 8 hours or 2 days to get to that clinic. I mean, it's unbelievable. So it was really helpful for me to get that perspective, and you know, thank God for those nurses who helped me. And so it's a good lesson to write down your traumas and your self-doubt, because then when you turn the page and you're feeling good about what you did, it makes you realize, like, you know, when it gets bad, like, just say, okay, tomorrow's a new day. And so there was a new day and a new day and a new day, and then from there I went to China and then to Kenya, and I spent a lot of time in India doing a lot of nurse training. These were Indian nurses. We did a big training in Chennai on HIV, and I helped develop the national curriculum for training of nurses in HIV, and now it's been used for, you know, millions of people. And it's so funny because I'll see it on a website or something. I say, oh my God, those are my slides from 2005. And it's just crazy that, you know, someone like me could have that kind of impact and be allowed to have that that privilege of translating what my knowledge in the U.S. to help people in a very different situation. And I know I better get a move on here. So this is the way it worked with rollout of HIV treatment in most low-income countries. So at first, as I said, there were these small groups. They were in urban hospitals, referral centers. It was thought to be very specialized. You know, you might have to be an infectious disease doctor to do HIV care, and it was mostly external support. So it was money coming in from the outside, and it might have been a partnership with Harvard or Johns Hopkins or someplace where they would send doctors in to treat people. Then once the drugs became available, so around 2004, 2005, they started moving treatment out to the district hospitals. And then they allowed clinical officers or medical assistants or something like a physician's assistant to prescribe antiretrovirals. And then the government started supporting. So all of these governments started to come up with their own plans, their funding. They started training their own physicians and nurses on HIV, their lab technicians, and obviously developing the national strategies. And then couple of years after that, they moved out to the rural health centers, and more it became nurse-initiated antiretroviral therapy. So in many countries, nurses are diagnosing and treating patients throughout the whole course of their disease. The problem with this is, like, they didn't add any nurses. So the same nurse who's doing the deliveries, the malaria treatment, the TB treatment, treating road accidents, etc., is now also being tasked with this incredibly important but time-consuming job. But we've made such amazing progress, and if you can see that dotted line, so in 2011, the United Nations set up these targets, and we have surpassed the targets now in 2015. And as you see, as the number of people on treatment go up, the number of deaths go down. But you'll see that the cases are still going up, but that's okay, because that means more people are alive. Yes, too many people are still getting infected, but people are not dying at the rate that they were before, so there's going to be more people living with HIV, but more and more people are living a longer, healthier life with HIV. So, what do you need to do a big treatment program in a country? And you need political commitment, and you need national policies and strategies. And I was talking to somebody, political science, yes. I mean, it is the most important thing. Not what the people know, it's whether or not that government wants to do something about this. For example, in South Africa, their previous president, President Mbeki, did not believe that HIV caused AIDS. And he believed that HIV was a disease of poverty, and it was a disease of the West, that the West had brought to South Africa. And he and his Minister of Health were advising garlic and beetroot as treatment for HIV. Up until 2006, at the International AIDS Conference in Toronto, South Africa's booth had garlic and beetroot hanging from the walls. People were outraged. The countries around them, the poorer countries, because South Africa is a fairly wealthy country for sub-Saharan African standards, all the other countries, Zambia and Namibia, Botswana, they were all getting their act together and getting programs in place and starting to put people on treatment. And South Africa, who had the highest prevalence, was doing nothing. So millions of people died because of that refusal of the politicians to acknowledge something that was fact. On the other hand, you have some countries that were quite poor. Rwanda, I've spent a lot of time in Rwanda. You know that they went through a terrible genocide about 21 years ago, and they were left with nothing. So many people, 1 million people were murdered in 90 days, and many people fled. And a lot of the educated people were killed or fled. So they were left with nothing. They have come back in a way that is amazing to everyone, and their health indicators are better than most sub-Saharan African countries. They have 93% of their girls over the age of 11 get HPV vaccine. Their vaccination rates, their maternal death rates have gone way down, their infant death rates. Now, they're not good, but they certainly are better than most of their neighbors, and they continue to get better. And why is that? Because the government decided that we are going to move from a low-income country to a middle-income country, and if we don't have a health system that people can use, nobody's going to invest in our country. So maybe it's not 100% altruistic, but it doesn't matter because it's progress in health, and it's a political commitment that makes it happen. Obviously, you need the funding. So you need funding that comes from the taxpayers of that country. A lot of them are really struggling with funding everything. So, but they do need to fund their health system. And outside funding is still necessary. Hopefully one day it will not be. You need diagnostics, you need drugs, you need the healthcare providers. For the last 5 years or so, I've been pretty much focused on health workforce issues and helping countries to determine what they have. How many doctors, nurses, midwives, pharmacists, lab technicians do we have? How many do we think we need? And how are we going to get from here to here? And so it's looking at how many are the schools producing, how many are actually graduating, how many are leaving the country, how many are going into other professions, how many are dying. And looking at all that and putting it together and helping them come up with a plan of how they'll get the numbers that they need. Or switch things around so that, you know, there's a lot of talk over the last few years about task shifting. A lot of people don't like that term. They like task sharing or whatever. But it's like just looking at the portfolio of each of the healthcare providers and what their jobs are. So what things can nurses do that doctors are currently doing? What things can a nursing assistant do that the nurse is doing, or a lay midwife that a midwife? So there's a lot of things around that, looking at what a proper health workforce would be. And then obviously access to care and treatment. So there have been many, many programs funded by the US and other wealthy countries in sub-Saharan Africa in particular. And I say that, you know, people always talk about partnerships, like we're partnering with so-and-so, but I've seen this wide range of definitions of partnering. And I break it down a little bit to say, like, cooperation, I think, is like the minimal level. It means you have permission to be in the country, but pretty much the project is yours. You've designed it, you're funding it, and it's your goals that matter. We see less of that now than we used to, but it used to be terrible. I have seen some university, US university, have told me that they're starting a nurse practitioner program in rural Kenya. And these nurse practitioners are going to do this, 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 this. And I'm like, really? Wow, what does the nursing council think about that? And they're like, nursing council? I said, yeah, well, we haven't talked to them yet, but we have our curriculum, and we have our trainers, and we have our job descriptions, and we're recruiting. And I said, oh, wow. So then I say to the nursing council, so I understand there's going to be a nurse practitioner program. And they say, it is not possible in this country. We do not have nurse practitioners. They are not allowed to do that. And I say, uh-oh. But how could that happen? How could somebody get funding and actually start implementing, and they never talk to the nursing council? How disrespectful is that? Really disrespectful. And I have seen it. Then there's what I call collaboration. So maybe some degree of joint planning. Priorities and goals may be informed by the country, but still the funds are controlled by the foreign organization, and the responsibility is to the donor. This can be also dangerous. I see it where a group might come in and develop a training program for nurses on HIV care, using what they use in the US, or some modified training, not taking into account that the government, the Ministry of Health, already has an approved curriculum. They already have approved drugs that can be procured. So if you're going to teach about using tenofovir, and tenofovir is not available in that country, then you're doing a disservice. If you're teaching things that are not approved, and those nurses can't use it. And they say, oh, well, we learned that you're supposed to start treatment at a CD4 count of 350. But the government says the drugs are only available to people with a CD4 count of 200. It's very confusing, and it's also disrespectful to that government that they're trying to plan for what they can do with the funds they have and do the most for the most amount of people. So I just see these things happening. But I'd say a real partnership, like if you talk about a partner, you have a business partner, it's something like you are mutually responsible to each other. You have a commitment. You have a legal contract. You have clear consequences for violating the contract. You have trust among the partners, and you have financial interdependence. It's not like, we've got this money, you can't see it, it's secret from you, but you tell us what to do with it. That also is disrespectful. And that's a big deal for us because in CHI we have certain values. We only work with government, so we work at the invitation of government. If a Ministry of Health tells us to work with a faith-based organization or an NGO, we would do that, but only at that request. So we work to strengthen the public health system within a country and help them to implement what they have decided they want to implement. So we see ourselves as we are contracted to them, we deliver to them. They tell us what to do, and we try to get them the resources and the people that they need to implement their program. One of our values is that we work with urgency. I think that if you talk to anybody in global health, they would say that we get things done quickly, and that we work with humility. So now I'm retired, so I can say that we really do great work, but we try to be humble. You won't see our logo on anything. You won't see our name. You won't see us taking credit for something. It will be the Ministry of Health of Kenya or the Minister of Health of Rwanda that will get all the credit, and rightfully so, for the work that they're doing. And that is drilled into us. If anybody violates that, Ira always says, you know, you can make a mistake and I will forgive you, but if I find out you were disrespectful to one of our government partners, you'll be out the door the next day. And that is the truth. So that's the way we work. And now I know not every group can work that way because the funding is different, and you have to be responsible to the people who give you the money. But you need, your mind, you need to always be thinking about the person you're serving. That nurse that you're working with, that pharmacist, that biotech engineer, that they're the person that owns this project, and you are there to help if you can, but not with your own agenda. So, I know I'm going, okay, I'm going to skip that. So, just a few bits of advice or things not to forget. So, every issue in global health is defined by politics, economics, and culture. Political will is the single greatest determinant of a country's ability to address its public health problems. Foreigners are guests. We're always guests. We have to remember that. We'll never understand the politics and culture as well as our in-country colleagues. So you could work in a country, you know, for 10 years, and you don't know it the way your colleague knows it. And we should never assume or act like we do. We're the guests. And there's no one right model. So you might think, oh, I worked in this clinic in Philadelphia. It was fabulous the way it was run. I think we should do this same thing in Kisi. We should have exactly that model in Kisi. But in Kisi, they've got a different model. So maybe they both would work, but it's their model. So that's the one we go with, not the one that worked in Philly. So, little advice. A lot of people come to me, a lot of young people come to me saying, I want to work in global health. What should I do? A lot of people say, I want to be you. How do I get there? And obviously from my story, you know, it's a little bit of serendipity, a little bit of fate, a little bit of luck, and a little bit of perseverance. But develop expertise in your field. The last thing anybody needs is somebody who doesn't know what they're doing. So if you're a new grad, you have no business going to work in another country. Get good at what you're doing. If you are, whatever it is, as I said before, there's all kinds of roles. They don't have to be clinical roles. There's so many things, but you need something to offer. If you're a neonatal nurse or a nurse anesthetist, or you're a certified public accountant, or whatever you are, get good at it so that when you go somewhere, you are a resource, you are an expert. You're not just somebody coming for an experience. I think that's really important. Continue to read the scientific and the lay press. I think about when I was first starting HIV and I didn't know anything about it, what I started reading was like the patient-based magazines. So I try to get, like, what does the lay press say about the antiretrovirals, or about testing, or about stigma? And then I'd move from that onto the scientific journals and evidence, or the nursing journals, and try to learn that way. And then, of course, I started reading about global health. Obviously, that's where I found out about the Clinton Foundation. I was reading an article on global health, and I saw that they were negotiating the prices. So, you know, keep reading and keep meeting people. I introduced myself to them at Brown, and it changed my life. So we have many people at CHI who maybe saw Ira talk somewhere and came up afterwards and just persisted and kept sending me emails and saying, I'll do anything, I'll go anywhere. And maybe they took a job as, you know, making copies in the Boston office or whatever. They took it because they really wanted the job, and then they proved themselves. So whatever job you get, if you find an organization you want to work for, and you take a job, just work hard and prove yourself. I mean, people will notice. I have hired so many people who were initially interns or volunteers because they just shine, and they're willing to do anything, and they work hard, and they're smart, and then something comes along and say, hey, how about that girl in HR? She's great. And that girl in HR who I hired in 2006, now she's getting her master's degree at MIT, but she was with us for 10 years and gradually climbed the ladder, and as a key person within CHI, and now she's getting her master's at MIT, and I'm sure she'll come back and do something with us. Be patient. You have a very long work life. I know sometimes at your age, it's really challenging to think, well, what's next? What do I do next? What's the next step? I got into global health at 50 years old. So I had a long work life, a long family life, life in the community that taught me. I learned from every single job I had. If you're dealing with patients, then you're learning therapeutic communication. You're learning skills of how to deal with people and how to respect people and how to respect their cultures. And you can translate that. I always say that, like, respecting and listening and talking with a patient is really no different than with a minister of health. It's like, it's just being respectful. It's like really listening. It's really caring. It's really reflecting back what they said to you. So whatever skill you're learning in the jobs you're in, like make it yours, and someday it's going to come back, and you're going to use it in a totally different situation, and you will really appreciate that. Be humble. We in the United States really need a lesson in humility, because we do have a sense that we know more than everybody else. We do have more than almost everybody else, but we just need that humility to know that the people we're working with are, and down here I say truly respect your colleagues and patients, truly respect them, because so many people are so smart, and so hardworking and have been through so much that you'll never know about. But you have to really respect them, not pretend to respect them. And strive to understand the political and cultural environment you're working in. I say you don't have to respect every culture, because some cultures are just, you know, they have some really bad things about them. If you're working in a place where, you know, women can't leave the house, or children are treated as property, or no, whatever, you don't have to respect that part of the culture, but you need to understand that your colleagues are coming out of that culture, are living in that culture. So, well, I don't say that you need to respect everything about a culture, but just try to always be cognizant of the fact that your colleagues and the patients have grown up in that culture and maybe struggling with it themselves. So it's something that we all need to be cognizant of. And that's it. I'm sorry I went a little long, but questions? Anybody? Yes.
I do have one. That was really fascinating, so thank you. But I would have to comment on your one thing about there is no one right model, but I think that your success could really provide some evidence for newer nurses as we're educating them about advocacy even in their own backyard. The first place we are instructing our undergraduates is to look at your evidence. So if you were to write up your model, even as a framework, I think it would be great evidence or a story of success, or concepts of successful steps that we could then say, there's your evidence to now build your, I'm sorry, could you write that up? But it's like, it's evidence-based practice for something that really has a gap when you look at evidence to support your practice as an advocate in the community in a way that could create programs that are sustainable. I just think it's a little bit of a gap, and I was really surprised when you're like, there's no one right model. I'm thinking, wow, yours was really pretty successful. So there's something right-ish about it.
Yeah,
and really,
yeah.
If we called it, you know, your framework. Maybe framework.
That's interesting. That's interesting. Somebody asked me that once before, I think at that conference at Vanderbilt. And she said, so whose model is that? Or whose framework is that? And I said, I don't know. I guess it's mine. I don't know. I wrote the slides. I made it up. So I guess it's mine. But yeah, I
think it would be really nice it would be really helpful as we're teaching young nurses to comb the evidence before they make a decision to implement something in practice. And I just think that there's, what little I do know about supporting the community, there's little nursing evidence to say, here's a framework or points to consider when you want to establish a project that's sustainable. Because you can translate adherence to the government, you know, having government support by saying, the organization you want to make this small project, and do they support it? You know what I mean? Like it's right. To me, it's translatable at a really local level. I think it would be really helpful.
Okay.
Not that I want to give you more work in your retirement, but I think it's really fascinating.
Anybody else? Nobody's going to ask me for a job.